So at this EHA meeting, we are presenting a result of meta-analysis of Daratumumab plus backbone myeloma regimens versus backbone myeloma regimens according to cytogenetic risk. And what really motivated this analysis is the fact that the three trials, randomized large trials that have been performed with Daratumumab in the newly diagnosed setting, that's specifically MAIA, Cassiopeia, and Alcyon. None of those trials show an improvement in a statistically significant improvement in progression-free survival among the patients with high-risk cytogenetics, defined as translocation 414, translocation 1416, or deletion 17p. So that has led to some questioning of whether Daratumumab is beneficial in this small but important subset of patients. And we hypothesize that some of that lack of significant result might have to do with the duration of follow-up. Some of that might have to do with the relatively small representation of those patients in each of those trials. So in order to address that, we Dr. Giri in our group led this meta-analysis that look across the literature for all trials with this design, backbone versus backbone plus Daratumumab, in both the newly diagnosed setting and in the relapse setting. And we identified the three trials that I already mentioned, the newly diagnosed setting, and we identified three trials, specifically Pollux, Castor, and Candor in the relapse setting. And when we look at PFS, according to cytogenetic subset, there is an advantage for adding Daratumumab in the relapse refractory setting. That was seen among patients with standard risk disease with a hazard ratio of 0.38. And that was also seen among patients with high risk cytogenetic with a hazard ratio of 0.45. But in the newly diagnosed setting, we saw an advantage in the standard risk with a hazard ratio of 0.45. But we also saw in the high risk subset an advantage for adding Daratumumab with a hazard ratio of 0.67 that was statistically significant. That indicates to us that while the effect of Daratumumab in high risk may not be of the same magnitude that it is in standard risk, it is nevertheless significant. We're talking about a 1/3 or 33% reduction in the risk of progression or death with adding Daratumumab. One, of course, caveat of a meta-analysis is the population on those trials can be quite different. But the important thing to remember here, to emphasize, is as part of the statistical design, there was an analysis for heterogeneity, and no significant heterogeneity was seen across the results, which really means there's no technical indication that the impact of Daratumumab on a backbone regimen is really affected by the design of the trial or the backbone that it's being combined with. That, I think, provides one more layer of reassurance for myeloma physicians that those regimens that employ Daratumumab are indeed applicable for patients with newly diagnosed myeloma with high-risk cytogenetics.